There is a subject in the last couple of years that's created a lot of controversy, and that is the subject of use of drugs to intubate folks. Now, the one question of does it remain in the paramedic scope of practice was answered by the board a couple of years ago, really. But there is a question that remains out there that I have been pushing since then, and yet it continues to kind of come up, and that is it time to retire etomidate-only intubation? Meaning, if we are going to use drugs, should we be doing it in the RSI fashion rather than with a sedative only? And the answer, of course, is yes to this, but I'd like to lay out some of the information about it. The question we're really looking at is the risk of sedative only intubation, specifically with etomidate, because that's what people have submitted as protocol requests. Is the risk of using sedative-only intubation acceptable when we know that RSI produces better results with fewer complications? Should we still allow people to use the less good way, the more dangerous way? So we have to define some terms. There's drug-assisted airway management or drug-assisted intubation, DAAM or DAI. Those are indicating that you use some kind of drugs, whether it's sedatives and paralytics, whether it's topical medicine, whether it's Benadryl, whatever you're doing to provide some sort of assistance to intubation. Then there is rapid sequence intubation, or RSI, which is where you give the sedative medication as well as a paralytic medication or muscle relaxant medication at the same time or almost the same time, and the idea is that the sedative takes effect, the patient falls asleep as the paralytic medication is kicking in, and that way it provides muscle relaxation. The other thing that's been proposed is sedative-only intubation, where you only give a sedative, which does not necessarily affect the patient's muscle tone or their ability to vomit or gag, and provides sort of half of the cocktail of RSI. Now, it is worth noting that RSI and drug-assisted intubation, and again, drug-assisted intubation is use of any kind of medicine. Rapid sequence and drug-assisted intubation is listed in the paramedic scope of practice in Kentucky, and that hasn't changed in several years. When we talk about sedative-only intubation, there are a few beliefs that, honestly, we need to dispel. The first of which is that RSI is more risky. It is potentially more dangerous. That is actually not the case, and I'll show you why, and I'll show you the data behind it shortly. The second one is that you have to do more training. If we can just get anybody credentialed to just use sedatives, but to use those paralytics, oh man, we got to do much more training. And I will tell you that if you are not providing the same level of training and the same level of oversight and the same level of QI that you should be doing for RSI program with your sedative-only intubation program, then you are doing something wrong and you're putting people at risk. There's this belief that sedative-only intubation means that, if we don't get the airway, we can just back out and the person will keep on breathing and everything will be fine. And that may work in a anesthesia setting where you can just cancel the case if you can't get the guy intubated. That's not our setting, though. These people need to be intubated now. That's why we're doing it specifically. We say they can't wait. They can't even wait the 11 minutes that it's going to take to get to the hospital. We can't stabilize them that long. We have to do it right this minute. So it's not an option to just back out and the person keep on breathing. That's why we're doing it. And that's not really a good argument for why you shouldn't use RSI. In fact, what you should do in that case is do everything you can to optimize your first attempt at intubation and provide the least risk to the patient. And then there's the statement that we do it just fine with just sedatives. And I will say, I don't think that even our own internal data backs that up. The truth is that RSI provides better intubating conditions with fewer complications. You have a better chance of first-pass success, which means less chance of complications when you use RSI. It is provides better success in difficult airway situations and better overall success. In general, RSI provides more benefits and less risk of complications compared to sedative-only intubation, and we should be using RSI rather than sedative-only intubation. Now, etomidate specifically is a bad choice for sedative-only intubation. If you were going to do it, you could maybe make a case to try some ketamine, which is a different sort of beast altogether. And even then, the data doesn't really back that up. But etomidate specifically is a bad choice for sedative-only intubation, but yet everyone says that they want to use it. The reason that it's a bad choice is because etomidate causes, in about a third of people that get it, myoclonus, which means muscle jerks, or masseter spasm. And that's, again, about a third of the people get it, 1 out of 3 people. That's a terrible side effect because it means that you can't get the person intubated when it happens because their jaw clenches, the exact thing that we're trying to avoid. And this drug is what does it. The simple fact is that RSI works with etomidate because you give them a paralytic with it and they can't get muscle contractures and masseter tone because that's the point of it. That's why it works with RSI, but you can't take out half of the drug cocktail and then expect it to work the same. RSI is safer for the patient and produces better success rates. We can back this up with some data. This was the use of etomidate in intubation in a air setting. And they were able to find, when we gave 39 people etomidate, we were able to get them intubated. But 12 of the patients that we attempted to do it, it was difficult or impossible, meaning it took at least 3 to 4 intubation attempts, which is a outstandingly high number, or was impossible to intubate. And about 12 of those folks, almost a quarter, or a little more than a quarter rather, had serious complications that RSI would have avoided. The authors of this study will go on to say etomidate's recommended as a sole agent for facilitating intubation only when rapid sequence intubation with paralysis is contraindicated or otherwise undesirable, meaning you should not routinely use it on its own. Here's another example of that. This is the effect of etomidate on airway management practices. The idea here was you could give a sedative and then wait and see if you thought you needed to give a paralytic with it, depending on what your intubating conditions look like. Here's their success rates. Eventually, they were able to get most people intubated after they got some etomidate plus maybe some other medicines. However, there was about a 75% complication rate associated with etomidate intubation by itself. And also, about half the time, you still had to give a paralytic with the etomidate. You couldn't get the person intubated with just etomidate alone. That's an unacceptably high amount to say this is going to be our primary use for it. Dr. Howard Werman, who was the one that, essentially said or promoted this idea to start with, said, "I hope that readers will not misinterpret our findings to support an etomidate-only RSI protocol. We continue to use succinylcholine as part of our RSI procedure." So they were not trying to say that etomidate is a good idea. You still should do RSI routinely and not sedative-only intubation. Another example here, these guys were looking at use of RSI versus etomidate-only intubation in flight services. They found that with RSI, you had much better intubating conditions in this blue bar here compared to the red, which is etomidate only. Much better visualization of the glottis, substantially less need for additional drugs, again, the red bar etomidate only, the blue bar RSI, and a much, much, much higher chance of successful intubation, 25% in the sedative-only group versus about 90% in the RSI group. Yet another bit of information, also looking at air services. These guys took 2 different services, one that always had RSI and then one that was moving from sedative only to RSI. What they found was that in the service they could RSI all the time, their intubation success rate was about 94%. Before RSI in the service that did only use sedatives, it was about 66%. Already enough compelling data to say we should probably just be doing RSI. However, when that service switched over to RSI, they found that that success rate went up to just about what it was in the first group. So it didn't appear to be the service, it appears to be the way that you did the intubation. Of note, after RSI was implemented, even if you, for some reason, only gave sedatives in that service, the success rate stayed the same. So it wasn't like they changed their training paradigm or something like that. It is the effect of the drugs and the way that you do it rather than something that went on differently with the service. So that is a durable change, and it is a result of the way that they did that. Also worth noting that about 1 out of 5 patients that you gave sedatives to later had to be paralyzed anyway to rescue them because they couldn't get them intubated without it. Not only does RSI produce better success rates, it also decreases the rate of complications. It's actually safer to use RSI in our patient population. Looking at a study of some of these things, this was a crossover study where the ED was transitioning to RSI from a sedative-only protocol, and they found that the rate of complications with sedative-only was substantially higher than with RSI, as were the number of multiple intubation attempts, the rate of esophageal intubation, and the number of folks that they were unable to intubate. All were significantly higher, and you can see the difference in those bars compared to RSI. Of note, there was no evidence of RSI causing airway trauma, no incidences of aspiration, no incidences of death when they adopted RSI. Whereas, for instance, in the death category, there were 2 that could be directly related to the way that they did it. And if the patient had been RSI'd, arguably those deaths might not have occurred. There's another more recent study here, and this was looking at ketamine intubation, so a sedative, a different sedative, but sedative only nonetheless, versus topical and sedative, which we don't really do, versus RSI. When they compared ketamine, the sedative only, versus rapid sequence intubation with paralytics, they found first pass success significantly higher with RSI, 90% versus 60%. First pass success in the setting of a difficult airway, the guys where we'd get worried about, were substantially higher, 87% versus 51% with sedative only. First pass success without any complications, substantially higher with RSI. What was higher with ketamine only was first attempt hypoxia, about double what it was in RSI. So more hypoxemia, about double the rate of hypoxemia with sedative only, and the chance of any adverse event occurring substantially higher with ketamine. So also worth noting that once again, about 1 out of 5 of these patients that got the ketamine later had to get paralytics as well in order to rescue them because they could not get the airway without it. So thus far, we have seen that RSI is presumably safer with fewer complications, fewer exposure, or less attempt to multiple attempts at intubation. And every time you attempt intubation and don't get it, the chance of complications goes up substantially in an exponential fashion after that. What if we put it all together? Well, the government did that, and AHRQ, who puts together some of these practice guidelines, and in this case, a systematic review, came up with this one. They basically looked at all the RSI versus sedative-only data, found that overall first pass success is better with RSI. Likewise, overall success is better with RSI. Not only do you get it more on the first time, you get it overall better when you use RSI compared to a sedative-only intubation. There wasn't a lot of data on harm just because there weren't a lot of included studies on it. However, when they did look at what happens just if you use sedatives versus no drugs in the pre-hospital setting, and they found that there was actually not a difference in first pass success if you used no drugs versus sedatives, and no difference in overall success or neuro outcomes. So even just using sedatives didn't have any substantial benefit over using no drugs at all to intubate the person and just wrestling the tube in their mouth. Again, the overall conclusions from this systemic review: in RSI and sedative only, RSI improves first pass success and improves overall success. Sedative only versus no medication found no difference in first pass success, no difference in neurological outcomes, no difference in the overall rate that they would get intubated together. So not only is RSI objectively better than sedative only intubation really has no evidence to say that it is better than no medication at all. The simple fact is that sedative-only intubation is not supported by data, at least that anybody can find. You might ask, is there maybe, there's a lot of stuff that we do that's not backed up by data, strong data, but is there national professional organization recommendation on the subject? You find that there's really not. This is an early piece from NAMSP about the time that all those studies were published, and the end result, if I'll draw your attention down to the right lower corner here, these studies collectively compromise only a small number of patients, but the same themes emerge: sedative facilitated intubation in ETI success rates that are borderline and that many would consider inadequate. We were seeing this in the early 2000s. There's a policy statement or a practice statement from the American College of Emergency Physicians on pre-hospital drug-assisted intubation, and while they say this isn't an advocacy statement for or against the use of DAI in the pre-hospital realm, what they do say is that their recommendation is that pre-hospital DAI programs include, at a minimum, the following elements, one of which is standardized drug-assisted intubation protocols, including the use of sedative and neuromuscular blockade. They spell it out right there. What about NAEMSP most contemporarily? This is their position statement on airway management, specifically on the use of drug-assisted airway management. And to drill down through the sort of dense part of it, basically they say multiple studies have shown that the use of any paralytic has been associated with higher first-pass success rates when compared to sedative-only intubation, as I've told you before. They bring out this sort of important statement. Given its significant risks and lower first-pass success, sedative-assisted intubation should be performed only by expert practitioners in select scenarios in which the risk of paralysis is greater than the risk of vomiting. In select clinical scenarios where paralytic use is unsafe, EMS clinicians should consider supportive airway techniques as an alternative to sedative-assisted intubation until arrival at the emergency department. Quite frankly, none of us qualify as expert practitioners if we are intubating once or twice a year, and especially if most of those intubations occur on patients in cardiac arrest, which are a different animal. NAMSP is fairly clear here. If you can't support using an RSI program, you should probably consider doing something other than giving sedative-only intubation when you get to the hospital. It certainly should not be. Sedative-only intubation should not be a routine practice for you. Now, there's no organization that recommends it. There's no actual data that support it, but is it just commonly used? We've been hearing that a lot, like, well, lots of services use it in Kentucky. Well, to be fair, only about 7 have actually used any form of drug-assisted intubation outside of the air services in the last 12 to 24 months, because we've looked at the data to see that. But is there any recommendation that somebody else across the country is doing that? Let's look at, say, textbooks. In this one, Bledsoe's textbook, sedate and paralyze using appropriate medications and doses. Most patients should receive both an induction agent and a paralytic. Doesn't seem to support the idea of giving sedatives only, at least in a routine effort. How about from the textbook for EMS physicians when you're doing your fellowship or when you're studying for your board exams? Sedative-only intubation is an approach that uses a sedative agent only without concurrent neuromuscular blocking agents. Most medical directors discourage this technique. They go on to say that from a system point of view, the training, the quality assurance, and the oversight has to be about the same, and adverse events associated with RSI may be at least as likely with sedation-assisted ETI, i.e., it's not safer. Sedation-assisted intubation with etomidate has been demonstrated to have lower success rates when compared to RSI. So it requires the same amount of work, the same amount of, if not more, risk to the patient, and you don't get the benefit that you do with RSI. What if we look at, other state? This was a study of pre-hospital protocols that were published, across a state. So in the same way that Kentucky has a state protocol that you can use, or a model protocol you can use, this looked at the number of states that have drug-assisted airway protocols. And what they found was that there are about 18 states that had published drug-assisted airway management protocols. 17 of the 18 had RSI as the option, and only one had a sedative-only option, i.e., that's us. Literally the only one that has a sedative-only option in this study. Well, maybe other people are using it and they're just not mentioning anything about it. Maybe medical directors all across the country feel this is actually a good idea. I asked that question, polled a group of 1,000 or so EMS physicians, and asked this question: sedative-only intubation, etomidate or ketamine without using a paralytic, intubation for standard non-critical care medics on ground ambulances as a routine practice. What do you think about it? Of the approximately 109 that responded, 102 of them said that's a bad idea. 7 of them said, if you used ketamine specifically, you might get it to work, but etomidate only is a bad idea. And 0 said that sounds like a good idea. Simply put, if the standard of care is what a reasonably trained person in a similar situation would look like, and that seems to be a reasonably trained group of people who are faced with the same question as us, if the question is what would they do in that situation, 102 of them say, no, I would not do that. That's a bad plan. 7 say, maybe you could make it work, but it's not ideal. And 0 of them support it. It doesn't sound like it's the standard of care. You might then ask, well, does our own state data support it? Because if we can do it safely, then sure. So I sort of asked that question, and the fairest way I could think to do it was I reviewed a randomly selected number of etomidate-only intubation in Kentucky over the last 12 months, and mostly I could see the narratives and some of the vital signs, at least what was documented and submitted through the NEMSIS data set. What we found was that 40% of these charts, representative sample randomly selected, had complications that RSI would have avoided. And that's patient significant complications that actually can objectively seem to provide harm or risk to the patient. 89% of the time, these intubations were performed for something other than refractory hypoxia. And usually that was, well, he had declining mental status, which we know is not actually a strong reason for intubation, and certainly not a strong reason for emergent pre-hospital intubation if you can manage their airway otherwise. None of these cases documented the lowest SpO2 during the intubation attempt, which we have to know for QA. None of them documented the time to intubate, which we have to know. And none of them documented if they met the national guideline definitive airway, sans hypoxia, and hypotension on the first attempt, meaning did you get the tube in the first time without the patient getting hypoxic and without making them hypotensive and sick. That just was not documented. And we have folks that are saying, yes, that we do great QA on this stuff. How can you do great QA on this stuff if you're not documenting arguably the three most important things about each intubation attempt? It's just not out there. When we do look at what's been documented, we find, again, a -1A, the airway metric that we should be using for these, definitive airway sans hypoxia on the first attempt. Did you do that? These are Kentucky data here. The highest percentage of -1A attempts is about 30%. That is abysmally low. Now it goes down to here in these couple of services, and I specifically block these so that you can't see who they are. Some of these services document a 0% -1A. Some are at 15%. The national airway metric that we need to be looking at is either not recorded or is documented, again, in the 10 to 20% range. And that's unacceptable, honestly. Just one other sort of interesting thing to look at. When services perform drug-assisted airway management on the ground in Kentucky, their median scene time is 25 minutes. Their median transport time for those same patients is 11 minutes. Often we hear, well, we have to be able to do this because we can't get the airway otherwise. Well, let's just say that you're not driving in these services that are doing drug-assisted intubation that are not air services. Your transport time is not an hour and a half down the road coming out of the mountains. It's only about 10 minutes or so. And most of these cases, looking at from a subjective standpoint, were maintainable by basic airway maneuvers or by non-RSI means. Let's just be honest with it. Of note, I wasn't just picking stuff out. The median scene time for most of these services when they're not doing drug-assisted intubation is 15 minutes, and their median transport time for patients that did not get drug-assisted intubation was about 13 minutes or so. So, drug-assisted intubation, we spend 10 extra minutes on scene of questionable benefit when the transport time is only a median of about 11 minutes to start with, which raises the question, should we be doing it at all? The simple fact is that sedative-only intubation increases the risk of complications while decreasing the success rate. It produces worse intubating conditions, and it's not recommended as a rule by national recommendation, extensive common usage, or expert opinion outside of a geographically small area of Kentucky itself. RSI, if we're going to perform drug-assisted airway management, is the safer, superior paradigm for drug-assisted airway management. And our patients cannot tolerate something that is less safe, less effective, and not standard of care. I've presented the reasons why this seems to be the case, that etomidate-only or sedative-only intubation does not seem to be safe, effective, or the standard of care. And, I would just like to close with this statement from Dan Spate, who's one of the big emergency medical services researchers and arguably airway experts in the country. And that is, he wrote a piece about this saying, we can no longer assume that because we believe we are improving patient outcomes, that this excuses us from verifying that we, in fact, are improving patient outcomes. We can't say that because our intentions are good and we think things look good that it actually avoids scrutiny on it. When we look with scrutiny at our current sedative-only intubation programs, they don't really pass muster. They're not supported by national data. They're not supported by expert recommendation. They're not supported by common usage, and they're not supported by even our own state data. Thus, it is time to retire sedative only, specifically etomidate only intubation in Kentucky, and move on to RSI protocols if we are going to be doing drug assisted airway management.